Hello, welcome everyone. I'm going to start. It's just about 1 o'clock. Thanks everyone for attending this BAPM webinar today. We're going to talk about the new framework for practice for bilious vomiting in the newborn and radiological support for neonatal services. This framework was published in the last year and was brought together with the collaboration of a number of different individuals. And I'd like to thank all of the people that were involved in finalising this framework. Hopefully, we'll hear from some of those people over the next hour or so, and we'll have a useful discussion. If you do have any questions about the presentations that you hear, we'll save the questions to the end. You can add your questions into the chat, or you can raise your hand at the end and put your camera on and be able to ask questions individually. So this is the plan for today. I'm Steve Wardle, I'm a neonatologist in Nottingham. I'm going to talk to you towards the end about the framework and the pathways that we've developed. But you're going to hear from Dr. Larry Adams, who's going to talk about GIRFT data and the background to this report. The report came about a couple of years ago when there was a recognition that it would be useful to have a national framework for around the area of bilious vomiting and about radiological services and neonatal units, but in particular around bilious vomiting because of an increased number of contrast studies which are being requested and required. And lots of babies being moved around and pressure on transport services as a result. There was, and there is still, unfortunately, variable access to contrast studies. And we'll maybe talk about a little bit about that today. And some variation in practice. So it was felt that it would be helpful to have a framework for practice in this area. Clearly, the thing that's behind a lot of this practice is the concern or worry about missing malrotation and volvulus, and an increasing anxiety about that, I think, has led to partly to this increase in the need for contrast studies. The GIRFT review and individual unit visits also identified this and some of the problems with radiology services. So I'm going to hand over to Larry now, who's going to talk about the GIRFT data and the background to this that led to the development of this framework. Oh, and just an acknowledgement of all of the people that took part in the working group. They're all listed here and they're all listed in the framework. But as you can see, we had representation from neonatal intensive care units, trainees, transport, radiology, surgery, nursing, local neonatal units, and networks. There isn't a parent rep identified on this. We didn't have a parent rep on the group, but the parent information leaflet was partly written and agreed with parent representatives. So I'm going to hand over to Larry.
Thank you, Steve. I'm hoping that my slide should now be showing. Is that correct? Yes, great. Okay, thank you very much for inviting me to talk today. So I'm talking with my GIRFT hat on rather than my BAPM hat today, but I'm absolutely delighted that BAPM have taken up the challenge to develop this framework following the findings and recommendations from the National GIRFT report. And so I'm going to be telling you a little bit about what those were today. So just for those of you that it's not moving on, just a minute. Okay, for those of you that are not working in England, just a very brief summary about GIRFT. So it's a National Quality Improvement Programme which is run by NHS England. I was able to collect data from any resource available to health services. So multiple data sources were available and I just chose which ones I felt were appropriate to review. Where there wasn't any data available, we collected information through questionnaires, which went out to the 156 neonatal units in England, and I got answers from all of them. So thank you to everyone for the important information that came back through that route. That data was then benchmarked to form data packs, across a wide range of variables for all the neonatal services, and also both at unit level and at network level. And I then undertook in-depth discussions with most of the individual neonatal services and all the networks, looking for areas to improve practice and areas where there was best practice that could be shared with others. And the main findings from this report were published at a national level, were published in the GIRFT report in April 2022. And there is a link for that if these slides are available. If you have an NHS email address, you can access the full report. Otherwise, there's a shortened report available. So what did we find? Well, obviously, with regards to bilious vomiting, access to upper GI contrast studies is really quite important for surgical diagnosis of babies who present with bilious vomiting, and in particular to rule out malrotation. And the questionnaire was used to identify what the access was like to upper GI contrast studies. And you can see from this that about a third of the NICUs have regular 24/7 access 7 days a week, with another third having access during the weekdays, but not out of hours. And a third don't really have regular access at all. And in particular, of those third of units that have 24/7 access, not all the surgical units have 24/7 access, which I think was a really important and surprising finding to me at the time. In addition to that, we can see that for the local neonatal units and for the special care units, this was significantly worse in terms of access. So having some kind of service available during the weekdays on a regular basis was only present in 20% of the LNUs and in 10% of the special care units. So there were significant issues with access, and I'm sure that our radiology colleagues will talk a little bit about the challenges around that later today. So with regards to the data around GI contrasts, we've combined two sets of data. One is the DIDS data, which is the diagnostic data set, and we've combined it with the HES data set to be able to look at GI contrast studies for term infants who were admitted in the first week of life, but had a contrast study within 2 weeks. And this is information that's getting a little bit older now, but I suspect hasn't changed greatly. This is for financial year 2018-19. There were just under 1,000 GI studies in the term infants. This is in England alone. And importantly, that data probably both reflects some data that's missing, because some of the children's hospital data was probably not quite as well captured, but also occasional duplicates due to the fact that we combined these two data sets. But this is the best data that we have. Only a quarter of the neonatal units were doing one study or more. So 3/4 of units were not doing any studies at all. And more than 50% of the studies were occurring in just 6 units, with in fact a quarter of the studies being done in 2 units. These are Southampton and Birmingham here, doing very much more studies than others here. And just on the deep dive visits, talking to people in their local units, we realised that there was a significant problem with access to paediatric radiology. So sometimes these upper GI contrast studies were being performed by paediatric radiologists on call rotas. Sometimes there was a shared service with adult radiology. In other places, adult radiology were not involved at all, and they were unable to get any kind of service. But additionally, on questioning the local units, we found that there was quite a lot of inequity of access to portable x-rays in an emergency. For example, not having radiographers on site 24/7 was occurring in some NICUs, particularly standalone NICUs that were standalone maternity units. So that was a particular issue. There were also accesses with highly variable accessibility to ultrasounds in various different hospitals. And in some hospitals, even in some of the bigger NICUs, there was a requirement for the neonatal services to do all the reporting, and there was no reporting being done by by the radiography services. So there were some significant concerns raised there. As a result of most of the service for upper GI contrast studies being really focused centralised into about 6 units really in the UK, but certainly most of it being done in 10 to 12 units, there is inevitably a large number of transports occurring for bilious vomiting. the National Transport Group data. I've given the data just for England alone for 21-22, which was what was included in the report. I suspect Kath may have some more up-to-date data. And that showed that there were just 780 transfers done by neonatal transport services. But we also know that 2 of the transport services were unable to transport all babies needing bilious vomiting. So this did not include quite a significant number of babies that are being transferred by local neonatal services. And there's, as a result of that, transfers being done by lots of different people, there was a highly variable quality of the transport provision. With some of the local units explaining to us that they really struggled with having enough experience and the right equipment to do transfers, and also with delays in access to transport vehicles through their regional transport services. And also teams, once the contrast study had been done, teams then being stranded at the tertiary hospital, not able to get back to their local hospital because they were now no longer considered to be an urgent transfer, so they could be waiting many hours with the baby waiting to go back. Some of the networks, and at the time it was really only 2 of the networks, had developed drive-by transport services for well babies requiring an upper GI contrast, trying to reduce mother-baby separation and unnecessary admissions. And certainly there's been a significant change in that over the last couple of years, with further transport services also starting to do this. And a recent letter in archives was just looking at what the results of that have been through quality improvement across one of the services. So what are our recommendations? So these recommendations were in the April 2022 report, and we very much felt that there needed to be improvements to the pathway for babies presenting with bilious vomiting, to reduce unnecessary transfers, and to reduce delays in access to surgical review and the upper GI contrast studies. And in particular, we felt that a national framework for practice was needed, which very kindly has been put together and is being presented today by BAPM. But I also would like to thank the other neonatal societies and professional organisations that were involved in doing that report. Now, I think that's been extremely important. This framework has also covered the second action point, which was around developing standards for radiology and radiography services for NICUs, LNUs and special care units. And indeed, there's also been progress from the networks around reviewing their pathways for babies with bilious vomiting and working with surgical services, transport services and radiology services to improve the pathway and minimise mother-baby separation, with consideration given to developing drive-by pathways for well babies. And that has indeed started to occur in many units. And that is the end of my presentation. Thank you.
That's great. Thanks very much, Larry. I'd next like to invite AJ to load his slides. AJ Sinnott is a consultant neonatologist at the Royal London Hospital, and he's going to talk to us about the published literature and the evidence behind our bilious vomiting framework.
First of all, thank you for introduction, Steve, and I'm delighted to be presenting the review of evidence from previous case series on behalf of BAPM Bilious Vomiting Framework Work Group. I do not need to tell this audience that bilious vomiting could be a sign of intestinal obstruction and indicate possible underlying surgical condition. We obviously have heard that we worry about small proportion of infants who have underlying malrotation and volvulus, which might require a discussion or transfer to a surgical center. Malrotation, as you know, results from disruption in the sequence of normal rotation. This then results in gut being placed in abnormal position, as you can see in this diagram, with a short mesentery, which predisposes these babies to develop volvulus and have at the risk of ischemic necrosis. Now, intestinal obstruction in malrotation can result from either extrinsic compression as a result of Ladd's band and or because of the volvulus. Now, while malrotation may be present in an infant, the obstruction can be dynamic, and I think this is an important thing to recognize. So the question that this framework group asked is, how often is the bilious vomiting caused by an underlying surgical condition or malrotation and or volvulus? And are there any predictors that can help us identify these groups of infants? So these are the studies, published studies that the group reviewed. You can see they are listed with the author's name on the left with the year of publication. So this represents the data collection from 1980s to 2020 onwards. They're from different part of the world, but a lot of studies from UK and at least 3 studies from Australia. Many of the earlier studies are considerably smaller in size, but the last studies from 2010 onwards, they have a reasonable number of babies with bilious vomiting in their cohort. Now, this slide shows the rates of surgical condition in a baby presenting with bilious vomiting. There were approximately just over 1,500 babies in this whole cohort, and of these, a quarter of babies had an underlying surgical condition. The individual diamonds represents the incidence in the individual studies, and the error bar represents the 95% confidence interval. I think you can appreciate that studies which have collected data from participants from 2010 onward appears to have a lower rates of underlying surgical condition, and that is around sort of 20% of these cases had an underlying surgical diagnosis. Now, a lot of variation in the rates can be explained on the basis of different type of reports, different case definition used in the studies. Maybe we can perhaps talk about these in discussion. And similarly, whether the antenatally diagnosed cases were included or excluded, inclusion or exclusion of preterm infants. And I know for today's discussion, we are focusing on term infant, whether the meconium stained Leica babies were excluded. And I think the most important, as we have heard, is change in the threshold of referral and the concern about missing a case of malrotation and volvulus that has resulted in increased number of cases being referred and perhaps a lower proportion of them having an underlying surgical condition. Similarly, looking at the rates of malrotation and volvulus, the data is presented in the same way. For this outcome data was available on approximately 1,700 babies, and overall, nearly 8% of babies in this cohort had malrotation and or volvulus. Similarly, the data from babies in these studies, which have been included from 2010 onward, had a lower rates of malrotation and volvulus as a proportion of overall group. And that works out approximately 6.5%. Now, we looked at whether these cases, either the surgical cases or the cases with malrotation and volvulus, can be predicted on the basis of basis of findings that are available before transfer. So that may include the color of the bilious vomit and aspirate, a clinical examination findings such as abdominal distension and tenderness, and or plain abdominal X-ray findings. Now, of course, here we are talking about green as a bile, and the question would be: is the different shades of the green, do they predict? Are there any difference in terms of rates of surgical cases in babies who have different shades of green? And I know we're in the process of analyzing that data, and we'll hope to share that soon with this wider group. So there are few studies which looked at abnormal abdominal X-ray as a predictor for underlying surgical diagnosis. And I think the sensitivity, which is perhaps the more important parameter in this case, in these three studies, varied from 85 to 97%. And the last study by Führer et al. Again had a significant association with abnormal plain X-rays and abdominal distension with the surgical diagnosis, although they did not report the sensitivity and specificity. Now diving a bit deep into these individual studies, for example, Oza et al. Had 4 cases which were a false negative for the surgical diagnosis. They had 2 cases, they had normal X-rays, but these 4 babies had clinical findings that would raise suspicion about the underlying surgical diagnosis. All of these babies had distended abdomen. While Kallis et al. Reported 5 false negative finding on the abdominal X-ray, these infants having malrotation, but there was no details given whether the examination finding would have assisted in identifying these babies. So I've talked about malrotation and volvulus in the previous slide as well. And you can see now the presence of abnormal abdominal X-ray had a sensitivity of 67% for diagnosis of malrotation and volvulus. Now, because we are talking about the small number of cases in each of these individual studies, missing few cases would have a big impact on sensitivity. And the authors do specify that these cases would have been identified by abnormal abdominal examination findings. Similarly, Führer et al. Had a significant association shown with abnormal examination finding and plain X-rays with volvulus diagnosis. They also used the combined parameter for the diagnosis of malrotation. And I think the most important information here to look at the negative predictive value. So for example, absence of abdominal distension and a normal plain radiograph had a 97% negative predictive value for the diagnosis of malrotation in healthy neonates and bilious vomiting. So I think in summary, our evidence suggests the recent cohort of babies presenting with bilious vomiting had a lower proportion of them were diagnosed with underlying surgical condition and with diagnosis of malrotation and volvulus. There is clearly a significant association with abnormal clinical signs as with underlying surgical diagnosis as well as malrotation. While the contrast X-ray is a gold standard, and absence of clinical signs and normal plain X-ray does not rule out the possibility of malrotation and volvulus. I feel the combination of the abnormal X-ray and the clinical sign can be used to risk stratify. Thank you.
Thanks, AJ. That was a really nice, concise summary of the evidence. So we're going to move on, and I think Nigel Hall is going to talk to us next. Nigel is a consultant surgeon in Southampton, and he's going to talk to us about surgical aspects of bilious vomiting.
Thanks, Steve. I'm not going to share any slides. I'm just going to talk, if that's all right. So as you've just heard, I'm a paediatric surgeon in Southampton, and I was one of 2 paediatric surgeons on this BAPEM working group as representatives of paediatric surgeons through the British Association of Paediatric Surgeons. So first of all, I just want to acknowledge that this framework, I think, is going to create some sort of anxiety amongst lots of people, surgeons perhaps in particular. And I think it's really important that we acknowledge that up front. And for some people, it may represent a slight change to what their current practice is. But I think it's also important to emphasize when we start looking at this framework that it is just that. It's a framework that has been produced in order to try and provide some guidance to centres, networks, transport services around the country to guide practice in this space, in this clinical condition. And the reason it's not a more formal guideline as such is really largely because of what you've just heard from AJ, that the evidence base that we have to inform clinical decision making at the current time just isn't there. And whilst, as AJ pointed out in his review of the evidence, it would have been really great to be able to come up with a set of criteria that could be used for the more objective assessment of babies to guide decision making and hence to guide practice. The evidence base at the moment just really doesn't exist. And that's why this is not more than a framework and why it's not a specific guideline as such. So I've been asked to talk about surgical aspects of bilious vomiting, and clearly one could talk for hours about that because there's a huge range of surgical conditions, let alone other conditions, that can present with bilious vomiting. And in some of those studies you've seen just reported from AJ, the incidence of having a surgical condition was at times as high as 25%. But in other series, it was also much lower. And that's largely, I think, due to, as AJ pointed out, the denominator of what the definition of having a bilious vomit actually was in each study, and what actually the indication for being enrolled in the study were. And he's alluded to many of those. So from a surgical perspective, bilious vomiting is clearly something that raises concern, largely because of this concept that it could be, in the absence of other features, the first presentation of a baby with malrotation. And as you all know, those babies with malrotation are sometimes at risk of midgut volvulus. And that is, of course, a condition that terrifies the pediatric surgeon, largely because of the consequences of missing that diagnosis. Missing diagnosis of midgut volvulus is inevitably something that drives fear into the heart of pediatric surgeons, because it has potentially lifelong consequences or life-limiting consequences if it is missed. And that fear has guided lots of practice. But equally, we need to acknowledge that bilious vomiting is a sign of a potential sign of gastrointestinal tract obstruction, that there are many other surgical conditions, and I'm just focusing on those surgical ones here, that may result in a bilious vomiting. And many of those conditions will be identifiable from other clinical features that are present at the baby through history taking, through an examination, or through basic radiological investigations, by which I mean typically plain radiology in terms of x-rays. And they range, of course, from upper gastrointestinal tract obstructions, things like duodenal atresia, and atresias lower down the intestinal tract, all the way through to distal intestinal obstruction for conditions such as Hirschman's disease, anorectal malformations, and so on. And as I say, many of those conditions are fairly easily distinguishable from other pathologies by history taking, the examination, and plain radiology. But of course, the main role for the upper GI contrast study is specifically in this context to identify babies who don't have any of those other features and in whom there is concern that there may be a diagnosis of malrotation. And what this framework aims to do is to try and facilitate the early, prompt, and rational investigation of this group of babies, whilst at the same time recognizing that there is an urgency to perform the investigation if there's concern that there may be a coexisting evidence of the baby being unwell that might be indicative of an underlying diagnosis of malrotation with volvulus. So if we consider from a surgical perspective what the aims of this framework to do, essentially it's, of course, to remain safe and to have a safe practice. It's also to facilitate decision-making, both at the local neonatal unit hospital and in surgical centres and referral centres and by transport services. And really this framework is setting out a set of concepts to inform local guidelines and practice. The aim of the framework is specifically not to reduce necessarily the number of babies having an upper GI contrast study. That might be a result of this framework, but that is consequent on better informed decision-making and assessment of babies rather than a specific aim of it. So if we come back again to the surgical ambition, which is to identify babies with malrotation as early as possible and to submit them to an upper GI contrast study early and to identify early babies who may have volvulus. I think there were some key take-home messages from this framework from the surgical perspective. The first of all is that these babies should have a really prompt assessment by a senior member of the clinical team. And that during that assessment, there should be consideration given to the need to consider a diagnosis of malrotation. I think that there has crept in, and the framework document makes it very clear, there's crept in this concept that every single baby who has any sort of bile passing its lips, be it in a vomit, an unwitnessed vomit, or an aspirate from a nasogastric tube that has been placed for whatever reason, needs to have malrotation formally excluded. And I think what we've learned over years from the drastic increase in the number of upper GI contrast studies that are being done, that practice does not make sense. But what we need to make sure is that we have a safe framework for identifying those babies who do need to have malrotation excluded. We need to make sure that having had the local assessment, each network has in place good practices, good open lines of communication between neonatologists assessing babies and their surgical counterparts, and that we need to make sure that we have decisions being made by the right people in the right time and in the right place. And often that may mean conference calls between teams, often at unsociable hours. But if that's what we need to do to make sure that we can provide a safe practice for these babies, that's the sort of working practices that this framework points towards having. We need to consider the timing and location of the upper GI contrast study. And this framework lays out very clearly something I think is safe practice and should be recognized to be safe practice from the surgical perspective as well, that if the upper GI contrast study can be performed locally and it is felt safe to do that in a baby, then waiting until the next morning, for instance, is a perfectly safe practice. But if there are concerns, then they should be voiced and escalated through the right pathways, and those mechanisms for providing a timely transfer for prompt assessment, including prompt out of hours upper GI contrast study, should be in place. And of course, the most important take-home message, if there generally are clinical concerns about an unwell baby who's presented with bilious vomiting, then that should continue to be a prompt referral direct to a surgical unit, no matter what time of the day it is. So I completely acknowledge that from the surgical perspective, there may be many concerns about the publication of this framework. And I think it's really important that we continue to work together to see how we can improve outcome for these babies for all the reasons that Ellery identified in the GIRFT review, because of the important implications that has for practice, but also for families. Thank you very much.
Thanks very much, Nigel, and well done for managing without any PowerPoint. That's nice, a really clear presentation. So we're going to move on to the next presentation, which is from Kath Harrison, who's a consultant neonatologist in Leeds and is chair of the National Transport Group, and she's going to talk about transport aspects of bilious vomiting.
Thank you very much, Steve, for asking me to talk on behalf of National Transport. So I'm just going to talk briefly about transport services for bilious vomiting. Next slide, please. So I'm just going to give you a brief transport overview and just share our national data from the Neonatal Transport Group 22-23. We've already had some baseline data from Larry from the GIRFT report. Then I'm just going to talk about current practices for transport in terms of bilious vomiters and the anticipated changes with the framework. Thank you. Next slide. Okay, so this graph just shows our annualized activity. So you can see that we do between 14 and 16,000 neonatal transfers a year. So a significant amount of transfers. And actually that is, we've now got 14 specialised transport services across the UK. We previously had 15, but there's been some reconfiguration with the Southwest merging into one team. But you can see it's a significant number of transfers that we're doing. And to put it into context, paediatric transport services do between 4,000 and 5,000 transfers per year. So we're doing 3 times that number. Next slide. So this is the number of babies transferred for bilious vomiting in our 22-23 data. I'd just like to say a big thank you to all of the NTG teams who provide data for this, and thanks to Alan Jackson and Colin Devon from Scottstar, who do a great job of collating all of our data year on year. So what you can see from this slide is there's a huge number of transfers that we do across the country. So between 2022-23, we did 727 transfers across the UK for bilious vomiting. So that's 5% of all of the neonatal transfers are for bilious vomiting. So 671 of these were done by transport services and 56 were done by non-transport services. And we know from what Larry said that these can lead to significant delays due to ambulance service provision. It can also lead to inexperienced staff carrying out these transfers, and actually families and staff being stranded after having a normal contrast study. And we know that looking at the map on there, that the grey bars are the transfers that are done by non-specialised teams. And sometimes that is because geography plays quite a big part in the decision about who is best placed to move babies for a time critical or immediate transfer. And we know Nest, which is based down in Bristol in the southwest, have got a huge area to cover. And us up in Yorkshire at Embrace, we get some of our local teams to do that because it's quicker for them to do the transfers than wait for a team to get there for 2 or 3 hours. And I think the other thing is the number of babies that we are moving for contrast studies for bilious vomiting actually can end up with an unnecessary admission to a surgical NICU. And we all know that the capacity currently around the country is quite problematic. Next slide, please. So this is just the last 2 years of data. So you can see there's not only variability around the country, but there's quite a large variability year on year about the number of transfers that we are moving. So why are there so many transfers? Well, we've heard from what Larry said from the GIRFT report that contrast studies are not available in all centres and not even in every tertiary NICU. And so these transfers that we're doing, sort of 600 or 700 a year, actually place quite a significant burden on transport services, reducing the availability of the transport teams for other sick babies and leads to unnecessary baby and mother separation. And we need to determine as a group, neonatologists, paediatricians, radiologists and transport services and surgeons, to determine which babies need an urgent contrast to exclude malrotation. Next slide, please. So this is one of the questions that we ask every year for NTG about which services class a bile stain vomiter as an immediate dispatch transfer. And you can see that it is roughly about 50%, but there is variation year on year. And I think quite a lot of regions and transport services are affected by that one case of a missed malrotation, and therefore they change their practice and make these transfers immediate dispatch. So they're currently not classed as an immediate dispatch criteria nationally for our KPIs for transport, but quite a lot of regions do have their own local criteria for immediate dispatch, again, because of previous cases. Next slide, please. So what do we mean by immediate dispatch? In the old service specifications, we used to call these time critical transfers, but the new service specification for neonatal transport is just about to be published, and we've renamed this as immediate dispatch. There are criteria for neonatology, so there's 5 criteria that we all count the same for national criteria for immediate dispatch. But as I said, bilious vomiting is not in this category, but some regions do class this as local time critical criteria. And the key performance indicator for this is that transport teams need to leave the transport base within 1 hour from the start of referral call to go and transport the baby into a tertiary centre with radiological support. So I've just done a questionnaire around all the transport services to get an up-to-date idea of what people are doing in terms of bilious vomiters. As I said, about 50% count them as immediate dispatch, but other services use less than 6 hours, depending on clinical presentation, and some teams just try and move them within 3 to 4 hours mobilisation time. So again, quite a lot of national variation in terms of timing. Next slide, please. So I also asked about drive-through potential. So from April 24, we have 3 services who are doing drive-through contrasts. We have 9 who said they would never do a drive-through contrast, and 2 sometimes. And the ones who can do a contrast study as a drive-through actually have some time limits, so they're only in the daytime between 8 in the morning and 10 o'clock at night. So it's very, very different from a geography point of view and really from what service provision people have. So the majority would actually take a baby for contrast, leave them in the hospital after a contrast, and they would be admitted to either a neonatal unit or a surgical unit for ongoing monitoring and management. Next slide, please. There also seems to be quite a lot of national variation across the regions in terms of were babies seen by a paediatric surgeon first prior to contrast. And what you can see is that 8 out of 14 teams said that yes, the cases would be seen by a surgeon before contrast. 2 teams said no, and 2 teams said sometimes, and 2 teams actually sadly didn't reply to the questionnaire. But a lot of teams said if they weren't seen by a surgeon before contrast, all cases would be discussed and accepted by a surgeon, and otherwise they would be seen after the contrast is complete by a paediatric surgeon. So I think surgeons are always part, it seems, of the referral call, but there has been some varied practice about whether they are seen and examined by a surgeon before a contrast study is carried out. Next slide, please. The other question we were asking was basically, do you wait for a baby to be on full feeds after a normal contrast? And this was the only consistent answer that we got, that actually no teams would do that. They basically would have maybe 1 or 2 feeds, and then they would be repatriated back to their referring hospital. Next slide, please. So I think really in summary, from a current transport practice, it's really variable across the country, and that I think is due to the geographical setup of transport services and regions. It's very variable in terms of surgical review. It's variable in terms of timings of mobilisation of transport services and classifying as an immediate dispatch. And there is only very few regions that are offering a drive-through service as it currently stands. The only consistent message was that no teams wait for the baby to be on 24 hours of full feeds before they would repatriate. Next slide. So I think from a transport point of view, what we really need is that these criteria should be fulfilled before babies are referred to a transport service. There does seem to be in some situations a knee-jerk reaction that if a baby has bilious vomiting, the first action is to call the transport service. But actually what we need is these babies need to be reviewed by a senior clinician prior to referral. We need to have had other causes of bilious vomiting identified and managed, for example, potential sepsis, and babies started on antibiotics. We would like the babies to be nil by mouth with a cannula in situ and IV fluids running and a nasogastric tube down on free drainage. Babies, as we've heard before from Nigel, need an abdominal x-ray done and reviewed by the clinical team, and also a blood gas looking at the lactate. And this, I'm sure, seems very obvious by most people on this call, but I can tell you these things do not routinely happen when babies are referred for transport. Next slide, please. But I think after all of this, the most important thing that we need from a transport point of view and from a baby point of view is that these cases need to be discussed at the same time with a surgeon, a neonatologist, and the transport service, mainly to determine the need for a contrast, the need for transfer, and actually the urgency of transfer. And that is what we need to get right. And everybody needs to be on the same call. We frequently get discussions with our surgical colleagues that babies have taken quite a long time to come in for a contrast study. And that generally is because these babies haven't been referred to a transport team, which is why it's much easier to do everything on a call conference. Then we all know what's being said and we can all have a good agreement on the plan of action and management going forwards. I think once we have decided that a baby needs to be transferred for a contrast, what we are asking referral centres to do is to be really prepared for transfer to help the transport teams, because the babies who need an urgent contrast need to be ready to go, so we can reduce our stabilisation time and get the babies into the right centre as quickly as possible. And so that means that our referring centres need to have made sure we've got working IV access, that fluids are drawn up and ready to hand over to the transport service, the notes and documentation are all in order. We have a maternal blood sample ready to take with the baby. And importantly, that the parents are updated and they know that their baby is going to be referred for a contrast study or a surgical opinion. So we can just speed up the process as quick as possible. Next slide. So I think this is a really useful page that you can see in the framework that gives you a really good idea of which babies need urgent surgical review and an urgent transfer. And then to think about other diagnoses. And then obviously there are a group of babies who will need a contrast for bilious vomiting, but it's not an immediate dispatch. And so that's a really helpful piece of information, I think, in the framework that we all need to use. Next slide, please. So in summary, I think from a transport point of view, we need a decision on a case-by-case basis. We definitely need these babies to be fully examined by a senior clinician. They need to have had an abdominal x-ray, a gas, and they need to be on antibiotics. And the most important thing is early discussion with surgery, neonatology, and transport through a call conference. And if there are any signs or symptoms of malrotation or volvulus, we need to move as an immediate dispatch. And we really need people to help for preparation for transfers, so we can do these transfers in a very timely and efficient manner. Thank you very much.
Fantastic. Thanks, Kath. That was a great summary. And you've covered many of the aspects of the framework, which I am about to talk about, which is really helpful. It makes my job a little bit easier. I'm just going to talk through the framework, and this you'll hopefully have all seen the framework already, but I'm just going to go through some of the flow charts that we produced and some of the information that we put into the framework, some of which you've already heard about from others' talks. So first of all, what is bilious vomiting? And we've put in this, what I think is quite a helpful colour chart. We've put this into the parent information document as well. I think we stole this from somebody else's guideline actually, but it's also similar information is published around colours of bilious vomiting. There is some debate as to what is significant, and as you heard from AJ, there is some current research looking at that and to see whether there's this, what the significance of particular colours of vomit are. But what we recommend is that it's the green colour of vomit which demarcates bilious vomiting from just other vomiting. But there is limited data in the literature about that. The other important thing that we tried to do in the framework is separate out the care of term babies from the care of preterm babies. With regard to bilious vomiting or particularly bilious aspirates in preterm babies, the causes are potentially different and the management should therefore be different. So we've set those out as separate flowcharts. So this is the flowchart for term babies. And by term, we've defined that as being above or equal to 34 weeks gestation. That's a consensus definition for the purposes of this, and one could choose slightly lower gestations if necessary. But it's more to do with the risks of other diagnoses, in particular necrotizing enterocolitis in preterm babies. But in term babies, which for the purpose of this we've defined as being above or equal to 34 weeks gestation, we recommend first of all that they're thoroughly assessed, and that you've heard that from several of the other speakers today. They need to be examined carefully and the history needs to be reviewed. We've added in that all babies should have a blood gas and a lactate. We think that's a useful investigation. Acidotic babies, particularly those with a high lactate, are unwell for some reason, and that the cause of that needs to be investigated. And that could be a surgical cause, it could be another cause. But the other question that needs to be asked is more support required? Is this a baby who needs either respiratory support or some other type of support? We included the fact that all babies should be started on antibiotics and have investigations to look for infection. That's because in the published data, as you heard from AJ, there is a small but significant incidence of infection amongst babies who have bilious vomiting. So from the published data, the incidence appears to be between about 6 and 10% of babies will have infection. And we certainly give babies on many other occasions for much lower incidences of potential infection than that. And so I think it's a reasonable use of antibiotics in this situation. And a number of these babies do have infection. The abdominal X-ray, as you've already heard, can also be helpful, and in particular for looking for other surgical diagnoses, particularly lower GI obstruction, which might be obvious, but also other causes of upper GI obstruction, which might be obvious on a plain abdominal X-ray before a contrast study is done. These are just some questions and prompts that we've put in the framework around the history and examination that is important to ask about and to carry out. I won't go through all of these in detail, you can read these, but these are just important parts of the assessment of these babies to make sure that all the potential diagnoses have been considered, and that if it's possible to make a diagnosis based on the information that's available at the time, that will help you to move forward in terms of making a management plan, rather than just a knee-jerk jump towards doing a contrast study that may or may not be necessary. And you've heard about all of these interventions from others. So moving further down on the flow diagram for our term babies, after careful review and assessment, if a baby's got acute abdominal signs or clear evidence of upper GI obstruction on the abdominal X-ray, or clear evidence of lower GI obstruction on the abdominal X-ray, those babies need to be seen by a paediatric surgeon. And so units should follow the care pathways in their network for referral to paediatric surgeons. That may include transfer if surgeons aren't on site for that particular unit. Those babies may not need contrast studies. It may be that in order to elucidate the exact cause that they do need a contrast study, but that needs to be done in liaison with a paediatric surgeon. There'll be some babies who are unwell, and particularly those babies who've got an abnormal blood gas or a raised lactate. It's important to think about infection in those babies, and I've already talked about the incidence of infection in some of these babies. There'll be some babies though, and these are the ones on the right-hand side of the slide here, that's coloured in blue. These are babies who have a normal pH and a normal lactate. They have no acute abdominal signs, and they have a normal abdominal X-ray. These are the well babies that probably make up a significant proportion of babies with bilious vomiting. These babies do need to have malrotation excluded as a potential underlying diagnosis, and these are babies that will need a contrast study. But these babies generally are not unwell and but they do need a contrast study organised and referral to a paediatric surgeon, and that might include a transfer. The next flow diagram tries to separate out which babies require more urgent and versus a more controlled and considered transfer. So for term babies with bile stain vomiting, we've divided it for the purposes of the of this framework, and I've used the old language of time critical and non-time critical, which I guess that might need updating now that the terms for these things have changed. But the babies that are defined as being time critical for the purposes of transfer are those with acute abdominal signs, those who are unwell with an abnormal blood gas or high lactate concentration, those requiring respiratory support or evidence of upper or lower GI obstruction. Those babies generally need to see a surgeon and need a time critical review. Those babies that we've defined as being non-time critical and can be transferred following local protocols are the babies that are on the right-hand side of the previous flow diagram. Those with no acute abdominal signs, those with normal blood gases and a normal lactate concentration, those babies who are not receiving respiratory support and have a normal X-ray, normal plain abdominal X-ray. Those babies still need a contrast study in order to exclude malrotation, but that doesn't need to be done in a time critical manner, and it can wait till the next morning, working day, normal hours. And as you've heard, those babies can return to their referring hospital to restart feeds once the contrast study is normal. So moving on now to the flow diagram for preterm babies. So as I've already said, in preterm babies, the key difference is the risk of necrotizing enterocolitis as one of the possible underlying diagnoses, but also the much higher incidence in this group of babies of feed intolerance. And there'll be some babies who are systemically well and are not tolerating the increase in their feeds well and have a small amount of bile stained aspirate. Those babies are the ones that fall onto the right hand side of this flow diagram. The ones that are systemically unwell that may have more significant underlying diagnoses have fallen to the left hand side, and we've used a colour scheme there to try to delineate that. So in babies who are systemically unwell, who have acute abdominal signs, we recommend that it's important then to hold their feeds, put an NG tube on free drainage, give antibiotics, perform an abdominal X-ray. And clearly there may be several different possible underlying diagnoses in these sorts of babies, but in particular necrotizing enterocolitis is obviously the thing that's at the front of your mind in a preterm baby with those sorts of systemic signs. On the other hand, in the systemically well babies who are preterm, who have some bile stain nasogastric aspirates, whilst there may be a very small risk of a malrotation in these babies, it's much more likely that there's some feed intolerance and excuse me, that there isn't a serious underlying cause. And holding feeds, potentially doing an abdominal X-ray, and assessing the situation might be reasonable courses of action in these sorts of babies. Infection needs to be considered, and X-rays are useful in terms of the assessment. But we think these flow diagrams help to separate out the general course of action that can be taken in preterm babies, separate from the term babies, and the need to do a contrast study to exclude malrotation in a preterm baby is much more unusual and much less common, because there are many more term babies than there are preterm babies. I won't go through this in detail, but this is just a list of assessment questions and prompts that we've put into the framework around assessing a preterm baby, some of which I've already mentioned, but obviously taking a careful history, carefully examining the baby, considering carefully the abdominal examination and assessing all of those aspects of the baby's care. So hopefully the framework can be used to formulate local guidelines and pathways, and clearly there's significant differences in geography, pathways and availability of contrast studies and surgeons in each different network. Which is why this framework is helpful as a framework, but each network should have a local guideline to guide what happens in their local area. And I know that many networks do already have guidelines in place. Malrotation is a risk and does occur in a significant but small proportion of these babies, but obviously other surgical problems can occur in a significant number as well and need to be considered. Think about other diagnoses and treat for infection. Discuss cases with a surgeon and neonatologist, and as Kath pointed out, a group discussion, a conference call with all of the clinicians involved is a really helpful way to move things forward. I'm not going to show you the parent information, but do look in the framework, and there is a parent information leaflet in there as well, which might be helpful to give to parents. So the other aspect of this guideline that forms part of it is the minimum requirements for radiological support for neonatal units. So we put this in together with this framework because the GIRFT review had identified that radiological support was lacking for some units. So we've produced some guidance, and we hope that can help to establish some standards in this area so that people have got some information that they can use to improve their service, to use towards cases of need or business cases when they're trying to argue the case for better support when some of these things don't exist. There's actually very little published information with regard to this, and the main source of this was the British Society of Paediatric Radiology recommendations, which were published in 2009, so a few years old now. But we used these and we added other recommendations based on consensus. Much of the work around this was done by Manju, who was one of the colleagues who was on the group, and did lots of work in producing these recommendations. These are all the recommendations. I won't go through these in details, but do look at these in the framework and compare them with the services that are available in your trusts. Just a brief summary here. We've recommended that all neonatal units at all levels, NICUs, LNUs, and special care units, should have plain X-ray availability 24/7, and that should come with daily reporting of those X-rays by radiology staff, as opposed to neonatal staff. The availability of fluoroscopy for contrast studies should be considered during daytime in all trusts where it's possible to provide that. In particular, for NICUs, we've recommended that there should be X-ray available clearly with daily reporting, portable ultrasound for head, heart, and abdominal scanning, the availability of fluoroscopy for contrast studies, and access to MRI scanning. Some of these things might seem very basic and very ordinary, but most of this stuff hasn't previously been in any recommendations or frameworks. So we thought it was important to have it there so that it can be used to argue the case for improving these services where they don't exist. So I'm going to end there. I'm just going to hand over to David Horton, who was the radiologist who was on the group as well. I think has got a few slides and going to say a few things about radiology.
Thank you very much. Yes, I'd like to do that. Welcome everybody to this radiology meeting. The framework is, I think, a very useful thing, but as you will have noticed during some of these pathways, that once you've entered into these pathways with your neonates, the imaging is inevitable and contrast screening is highly likely. On that point, you reach what I'm hoping you can see on the sharing screen is the radiology three-body problem. And the first part of that problem is the people. Radiology is a shortage speciality. The healthcare network that I'm part of, which includes 5 hospitals, has about 70 consultant radiologists, and we should be by April short of the number needed by 27. We'll have 27 unfilled vacancies. And that's in general radiological terms for all its specialities. Pediatric radiology is in itself an area of recruiting crisis. Many departments you'll find around the country overcome some of this by outsourcing their reporting. So out of hours, and perhaps even during hours, when pressures are high, a large number of radiographs, CT scans, MRI scans will be reported by organizations, private companies, who have their radiologists and other people around the world performing the studies remotely from anywhere. And at a certain expense. And so there will be nobody available to discuss it on your site so out of hours a lot of the time for many hospitals, and perhaps even occasionally during the day. And that is a particular issue. And then there's the psychology. Most children's imaging is performed by radiologists who do not pediatric radiology is their specialist area. They do this because most children have very similar conditions they're comfortable with managing. There are many what we might call a general radiologist who would be very happy to comment on a chest x-ray of an asthmatic 9-year-old. And there's probably quite a few general radiologists who are prepared to do an ultrasound scan, providing they do ultrasound, of a possible appendicitis in a 12-year-old. But babies, well, they're a little bit different to the rest of humanity, and their imaging is very, very different, and they intimidate a lot of radiologists. Neonatal imaging is the area of radiology which frightens most trainees, and that's the one that they're most scared of. And as part of the framework has identified, there is increasing over the years a risk aversion and an anxiety over the diagnosis of bile stain vomiting and potential complications. Well, guess what? It's the same in radiology as well. There's an increasing risk aversion anxiety. People don't want to get involved with things that they're not used to and that scare them. And this is one of those topics. So we have a problem with the number of people, and we have a problem with those that are there, willingness to look at neonates. And then there's the technology. Now, the traditional and gold standard, as still is contrast screening, radio opaque contrast screening into the GI tract. Now, that as a technique is actually in diminishing amounts of people who can perform that. One of my colleagues is a gastrointestinal radiologist, and she never has and does not now perform any upper GI contrast studies. It's almost entirely become an MR and CT, but mostly MR speciality. So fewer and fewer radiologists, where they exist and are prepared to look at a baby and they're actually in post, will perform upper GI contrast studies. The newer technologies which are coming along, such as ultrasound, to look at the position of the duodenum, and the position of the duodenum is key for this diagnosis, for these sorting these babies out. Well, that's a pretty skilled area that quite a lot of pediatric radiologists will be unfamiliar with using, and certainly a lot of the general radiologists there. Maybe at some point in the dim and distant future, when we're all aboard the Starship Enterprise, you'll be able to use your own ultrasound machines and work out these things yourselves, but I think that is quite some time away. Of course, then there's plain film, which has been mentioned, and if a plain film shows, oh my God, this is a surgical abdomen, that's tremendously useful. If it perhaps shows that the nasogastric tube is a little bit further down than you might have expected, and from my perspective, one of the commonest reasons for a bile stain aspirate from a nasogastric tube is that it's migrated through the pylorus, which is a perfectly legitimate reason for aspirating bile, but also a perfect opportunity, if you don't pull the tube back, of putting a little bit of contrast medium down and taking an abdomen radiograph and seeing what the duodenum is. At least you can have some information if it's the only thing you can get to. So we have the people, the psychology, and the technology of this 3-body problem. And a bit like the other 3-body problem, what is the solution? There isn't really a solution that's easy to see. It's a very, very complicated area. So from my perspective, I don't want to labor you with hundreds of slides. What is the answer to this? Well, the answer to this, I guess, is there isn't an easy answer to this, but I would say look after your pediatric radiologists. If you have them, nurture them, love them, take them into your lives, give them cake, anything to keep them happy. And also, when you're looking through these framework at the standards that have been set, and if there are areas which you can develop and you can push in business cases to make this this a reality for you, do so and bring your radiologists on board with you. Thank you very much for listening.
Thanks very much, David. No, that was helpful. We will remember to bring you cake next time. We've got a little bit of time for questions, so I can see a couple of hands already. So I think Abby Simmons was first.
Thank you very much. Yes, hi, I'm Abby Simmons. I'm a consultant neonatologist in Plymouth and also transport lead for the south of the southwest. I really welcome the framework, and I would hope that you know, with our large majority of babies that we're moving about the country at the moment who are fairly well, that it would give an opportunity for those well babies to have their contrast studies done in a slightly more relaxed manner, and hopefully locally where that exists. My question really is just about the framework talks about that, and hopefully getting local contrast studies and the opportunity to avoid transport altogether. However, the flowchart also says surgical review before contrast. And I just wanted to clarify that that hopefully means that there'll be a conference call including a surgeon to discuss the case, for them to look at abdo x-rays, etc., rather than they need to be moved to be seen by a surgeon, and then that completely negates us getting a local contrast study. Thank you.
Thanks for that question. I think it might differ from area to area, but Nigel, do you want to answer that? Should a surgeon always see a baby before a contrast study?
So I think that the way the framework is designed, and as Abby, you were just saying, encouraging local contrast studies, and clearly a hands-on review is going to be not possible. And I think this framework is hoping to rationalize some of the decision making, specifically to avoid some of those transfers. So I think it's entirely appropriate for the local contrast study to be done when the baby is well. There will be, I suspect, a difference of opinion amongst different networks around the country as to whether every single baby that the local team are wanting to do a contrast study on want to talk to a surgeon first or not. And I think those are important pathways to develop locally. But I think, as you heard, particularly from Kath, that these discussions are probably best held with senior members of each of the teams held. And if that's on a case-by-case basis that we also heard from people, I think that's entirely appropriate. So do they actually all need to be seen? No. But if there are local processes that recognise that it's useful for everyone to have a discussion about each baby, then I think that would be entirely appropriate. But those pathways should be developed and agreed locally, and the right processes put in place to allow for that to happen.
I can see that in the chat there's some discussion about ultrasounds, and that, David, you mentioned ultrasound as a possible mode to diagnose these sorts of problems as well. And I know this was raised in some of the comments that we got back around the framework. It seems that ultrasound is available in some areas to use for this purpose, but I don't think it's widely available. Is there anything more you can say about that, David? Is it something that maybe we'll work towards over time?
Oh, I think there's something that'll be well, the things the ideas are taken up fairly quickly and very enthusiastically by a small group of people, and then as it spreads out to a more wider use, you find there are problems with it, and people can't operate it with quite success, and its popularity declines quite markedly, and then eventually you settle down into a proper state. I'm aware that there's quite a bit of excitement about the uses of ultrasound in all sorts of ways, in the chest, everything in neonatal units. And I'm waiting for this sort of see how it sort of mellows out. you can give a water, well, even water soluble. There is a contrast medium used in ultrasound, which you can give a bubbles, which you can give through a nasogastric tube, fill the stomach, or even better still, a tube that's in the duodenum, and you can image the duodenum contents as it passes across the midline and work out its anatomical relationships to the superior mesenteric artery and so on, and work out if the duodenum is in roughly the right place. You can identify quite a bit of pathologies there, including the layer of the duodenum, which answers some of the major questions that you'd be looking for in an upper GI contrast study. But you have to have someone there to do the ultrasound scan, and they have to be used to doing it, and you have to get a good view. And the number of people available to do the ultrasound scan is probably less than the number of people available to do the screening. So there is that issue about getting it out of hours. But out of hours ultrasound is more difficult to get than almost everything else. And familiarity with using contrast agents, or even just I mean, I've used bubble agents on the neonatal unit very successfully to look for a number of different conditions, for putting it to the bladder, to see if there's any reflux to the kidneys, and extravasation from the bladder when there's been a damage caused by a line and seeing any leakage there. You can use expensive stuff, or you can just get a bag of saline and shake it in your hand until there's bubbles in it, and then inject that quickly. But yes, this is something that potentially, with more ultrasound units and point of care ultrasound on neonatal units, and more familiarity with doing that by neonatologists, that they may be prepared in the future to do this themselves. But my expectation of the rate at which will occur is that we will probably have a moon base and probably a Mars station by the time that that's actually in place.
Quite possibly, thanks. I can see another hand there. Nanda and Rantnavel.
Thanks. I'm from the London Neonatal Transfer Service. It might be that my kind of reflection on the discussion is a little bit influenced from the London perspective, which may not necessarily be nationally representative. But I put it in the chat. I mean, I guess I was hoping that we might be able to do fewer of these transfers, and that surgical cots, which are generally at a premium, wouldn't necessarily be occupied with, babies with negative studies and negative pathology in the end. So what I'm kind of gleaning from this discussion is that the time criticality element might be altered going forward, and that can be something the transport group picks up. But at the end of the day, the resources are still going to be utilised, if not immediately, but the next day, because we're still talking about the framework. The flowchart still suggests that term babies with bilious vomiting, whether they're well or unwell, will ultimately be transferred to a surgical centre. Whether that's a drive-through or whether that's an admission and then return. So I'm not sure about how much of a dent we'll make in sort of the resource availability. But that's not to say, I think this framework will be super useful. And I think, building reassurance around what is currently a lot of knee-jerk practice, and certainly in London, I think we see that, will be helpful. So it was just a comment, really. Thank you.
Thanks for the comment. I think it'd be fair to say that when we set off to write this framework, we were hopeful that we might have the same effect, that we might be able to reduce the number of babies that were being transferred and reduce the number of contrasts that we're doing. But having reviewed the evidence and worked out a consensus, it didn't quite prove as successful as we hoped it might be in terms of doing that. But I think we've produced what is a useful framework that helps to guide practice. Sarah McCulloch? See a hand?
Hello.
Hi.
Hi. Sorry, my camera's not working because I'm at work, and the computers are not very good. So I'm Sarah. I'm one of the consultant neonatologists at Royal Oldham, near Manchester. We are a level 3 unit without any surgical services or paediatric surgical services. Our main problem is the babies on the right of the flowchart that are well, but have bilious vomiting, and we cannot do contrast slow on site because the radiologists have said there's no surgical backup, so they're not happy to do them. And I'm just wondering if there's any alternatives. I saw digital fluoroscopy on the excuse my ignorance, but I was just wondering what that involves, because we have really good paediatric radiologists, and I will remember to bring them cake next time I see them. But they're very good, and they're very keen, and are always happy to review X-rays and things like that for us. But they're just a bit, you know, we're not going to do contrast studies if we don't have any surgeons around, just in case things go wrong. We've discussed
Perhaps you
about
can use the framework to take to them to show them as evidence that it is possible. But David, do you have any comments on that?
The reason for wanting surgical team involvement is anxiety. It's because if we find something, what are we going to do about it? And that's the concern. You're very unlikely for an upper GI contrast study to cause a surgical complication. I mean, there's certain procedures you do from the bottom end where you would really want to make sure that you've got someone who can cope if you perforate something. But if you're just giving a drink, then you shouldn't really have an issue. But the mostly that it's about the anxiety. What do we do about it afterwards? What happens if something goes wrong? Panic, and that's it. But strictly speaking, I have referrals for upper GI contrast studies for which have come from neonatologists prior to discussion with surgeons, following discussions with surgeons, from surgeons. So I know this in many centres. This can come in very different ways. It comes in different ways in one centre. And you read the particular question about digital fluoroscopy. We're just not using film anymore. Everyone's digital, really. It's all on.
I think their main concern is that they might cause perforation. I think that is their main concern.
Well, I don't see. Well, no, I don't think that really happens, and I don't really see how you can make it happen. I'm glad to see Nigel sort of agreeing with that. But as if you're pushing something through something, you're more likely to cause a perforation by putting a nasogastric tube through the esophagus than we are doing this study.
I mean, I think it's also because of the interpretation of the contrast study, though, as well.
Well, I would say from we do, as pediatric radiologists, we do like to sort of dress up what we do as being really difficult and complicated. But the upper GI contrast study for malrotation is probably the easiest contrast study to do. It is a 5-minute job, and with maybe 2 films, and you've got the information you need. Is walk in, walk out. Really, the drive-through bit. I go.
Have we lost David?
I think we've lost him. Yeah.
He was in mid-flow. That's a shame. Hopefully he'll come back.
Yeah, I'll try. I'll send them the framework and see. Thank you.
Yeah. Any other questions? I can't see any other hands.
Oh, something happened there. I don't know if I disappeared.
Oh,
you all disappeared from my view. But I should stop talking about Star Trek. I'll be replaced by a hologram. I forgot what I was saying. Yeah, I've completely lost. I've lost even my brains through that disappearing. What was I talking about?
This week.
Oh, you know what it was. Just. No, I've yet to meet a surgeon. I don't think I need a surgeon. It's not something we generally need to collaborate on. We generally look at the contrast study and agree. We do. I mean, I collaborate with surgeons all the time. If it wasn't for surgeons, I wouldn't have a job really. But I don't think this is an upper GI contrast study. Isn't something that you really need to have a conference call about the results, other than what the result is, because. If it doesn't fit with the context, and that's really that's really come in. If you find something which doesn't fit, but presumably you're doing an upper GI contrast study because you think they've got a possible malrotation, and if it shows that there isn't one, then you have to think of something else. Now, there's the discussion. That's where you really do need to have the discussion of what else you should be thinking of. And if we find something which isn't malrotation but is surgical, then you definitely need to have some discussion of what the possibilities are and what else you need to do. But for a normal drive-through screening, I don't think you need to be having a surgeon and the radiologist in the room at the same time. I wouldn't want to make the surgeon turn up for that, really.
All right, thank you.
Great, thank you. I think we've got time for just one more question. So Anne Apute.
Yes, that's Rainer Bell from the Royal London Hospital with Anuput's log on. I'm one of the consultants of the Royal London, which is a medical and surgical unit, and we get a lot. And the NTS, Dr. Mohannuddin, Said Mohannuddin, he's done one of those, was the main author of one of those papers, which was mentioned by Ajay earlier already. Now, there is a couple of things that I always think about when I think about malnutrition. One of them is, of course, 1 in 100 people have been shown in postmortem studies, I think latest time in 2016 or something like that, to have malrotation of some form or description. And I don't know how significant some of these malrotations that they found in the postmortem studies are, but it's only, I think, 1 in 6,000 babies or people who will suffer from volvulus. So if one makes a rough numbers from that, is only 1 in 60 people with some form of malrotation will have a volvulus. And if all babies that will have a bilious aspirate or vomit at some stage will be having a contrast, then we will probably pick up a few babies which then will have malrotation. And if somebody asked for contrast because of a bilious aspirate or vomit, and then there is malrotation, then the surgeons will often will almost feel compelled to do a laparotomy, which is quite a big procedure, and which maybe not all these babies need. But it's a tricky thing, because how can we possibly say which one is the one which has the malrotation, which will get a volvulus later? So for some, in some way, the question can never be black and white, 100% resolved, and we all need to be considering each individual case. And thank you very much for discussing and presenting this framework and your presentations to that. And I think it has to be individualized. But because also not all patients with malrotation will have a volvulus later, I think it is wise, if a contrast study is performed, that the pediatric surgeon is involved at that stage. I think for me, that sounds to be a wise thing to do at that moment. So for me, is always, do I want to have a contrast study? And then if that's the case, I want to have the surgeon involved in that decision, because I don't want to impose on them a finding of a contrast study that they would not have wanted to have done, if that makes sense.
Okay, great. Thanks for the comments. Nigel, any comments about incidence of malrotation? Do you see it lots in patients that you're operating on for other reasons?
No, is the short answer to that. Ever so occasionally, but as has been said, there are we think many more people who have malrotation than clearly who have malrotation with volvulus and present to us. Many more people, more babies have a bilious vomit than have malrotation. We know that from the number of negative contrast studies that are being done. I think the question's probably question has probably answered their own question, that yes, that there is a problem and an individualized approach to each baby with decision making based on aspects for that baby, based on their clinical situation, is undoubtedly the best approach. I think from a surgical perspective, the problems that surgeons have is that once the question of malrotation has been raised to us, we don't have any good means of excluding that diagnosis other than doing the investigation. And because of the consequences of missing it that surgeons are all too aware of, once it's been raised as an entity, it's very difficult to not do the contrast study. And so we've also heard here, I think, that this framework may be unlikely to reduce the number of contrast studies. And I said in my little talk that that's not the aim of it necessarily, but it's more to have perhaps a more rational approach to avoid this knee-jerk reaction that there is to doing a contrast study in every baby who has a tiny bit of bile from somewhere. I think probably there are a group of babies who have more definite evidence of sepsis, who may end up having fewer contrast studies in, because I think the knee-jerk reaction has extended to that group as well, if I'm honest. But the primary aim is not to do that. But then in relation to this concept of reducing transfers and reducing use of surgical beds, well, the key to realizing that benefit is to build the capacity at local units for having local contrast studies. And I think particularly, as we've just heard, in level 3 units where they've got some pediatric radiology cover, but where those contrast studies are not done there at the moment, that's a real opportunity to try and influence our services through this framework. And I would really support that, because that's where the benefit may lie in terms of minimizing transfers, resource use for transfer services, for clinicians, for pediatric radiology in various places, but also this important concept of separating babies and mothers early in their life. Yeah.
Right, agree. Thanks very much, Nigel. Last comment, David?
Yeah, I was just looking at some of the in the chat there, and I just don't want to leave the wrong impression with people as we leave there. I love it when the surgeons come and see me when I'm screening or when I'm at work. It shows they care. There are many of they're all my friends anyway. We have meals. It's a good thing to come and discuss cases. All discussion's a good thing, but I wouldn't insist that they were present for this particular study because they've got better things to do. And if it's normal, they're probably not going to be that interested unless there are other issues. Thank you. I'll shut up now.
Thanks very much. And a big thank you to all the speakers. I think it's been a really helpful and lively discussion of this framework today. So I think that's been really, really useful. We'll call an end to it there. And again, thanks very much to everyone that contributed to the framework and all those that have presented today.